Hey there, welcome back to Midnight Med. This video is on gestational diabetes. Gestational diabetes is common in pregnancy, most often presenting asymptomatically and identified during routine checks. It may present with the classic hyperglycemic symptoms like polyuria, that is, increased frequency of urination, polydipsia, that is, increased appetite, and fatigue. Weight gain and elevated pre pregnancy BMI can sometimes be flags that a woman may develop or may be developing gestational diabetes. The term gestational diabetes refers to diabetes that is first recognized in pregnancy. This is a subset of the broader category of syndromes known as diabetes in pregnancy, which includes gestational diabetes as well as those women with pre existing type 1 or type 2 diabetes. Importantly, women with pre existing diabetes are not considered to have gestational diabetes when they are pregnant. The pathophysiology of gestational diabetes is not fully understood, but metabolic and hormonal changes in pregnancy seem to add to an existing predisposition to cause gestational diabetes. Increased levels of human placental lactogen, estrogen, progesterone, and cortisol, in addition to altered expression of IRS1, PI3 kinase, GLUT4, and PPAR gamma, mediate insulin resistance in normal pregnancy. There is a pro-inflammatory state seen with gestational diabetes, with cytokines released from the placenta and maternal adipose tissue. Importantly, TNF alpha inhibits IRS1 to cause insulin resistance. Leptin metabolism is also dysregulated, stimulating inflammation while having its role in insulin sensitization attenuated. Risk factors for developing gestational diabetes include a pre-pregnancy BMI greater than 30 kilograms per meter squared, a sedentary lifestyle, hypertension, prior gestational diabetes, or a previous macrosomic baby, increased maternal age, so that's a woman that's older than 40 when she becomes pregnant, a family history of diabetes, and being of Asian, African, or Pacific Islander descent. Gestational diabetes can have some significant complications, which is why such attention is paid to it during pregnancy. There is an increased risk of gestational hypertension, preeclampsia, and eclampsia. There is an increased risk of macrosomia, meaning a risk of birth trauma, shoulder dystocia, neonatal hypoglycemia, and caesarean delivery. Long term, gestational diabetes can predispose to diabetes and cardiovascular disease in the mother, as well as metabolic disorders in the child. The risks to the child can affect them in adulthood as well. The gold standard for investigating gestational diabetes is a 75-gram oral glucose tolerance test at 24 to 28 weeks gestation. The thresholds used are 5.1 millimoles per litre at the time of the test, 10 millimoles per litre after 1 hour, and 8.5 millimoles per litre after 2 hours. An elevated blood glucose value with respect to any one of these thresholds is sufficient for a diagnosis of gestational diabetes. So, for example, if a woman has a level of 11 millimoles per litre at 1 hour and 6 millimoles per litre at 2 hours, she is elevated on at least one threshold and is therefore classified as having gestational diabetes. And importantly, as I mentioned before, this diagnosis can only be made in a woman that has not previously been diagnosed with diabetes. The management of gestational diabetes is based on regular blood glucose monitoring, diet, exercise, and potentially even insulin. Blood glucose levels are taken on waking and then again within 1 to 2 hours of each meal. Diet-wise, the woman's caloric intake should be guided by BMI and distributed throughout the day. Carbohydrate intake should be controlled. Moderate intensity aerobic exercise should be performed for 30 minutes per day as well. If these measures are insufficient and further glycemic control is required, insulin is used in a pattern-dependent way. If the woman's blood glucose level is normally elevated when fasting, then basal insulin is used. If the woman's blood glucose level is normally elevated postprandially, then bolus insulin is used before meals. If both of these conditions apply to the woman's blood glucose pattern, then a basal and bolus combined regimen is used. With all of these measures, target blood glucose levels are 5 millimoles per litre when fasting, 7.4 millimoles per litre 1 hour postprandially, and 6.7 millimoles per litre 2 hours postprandially. So that's it. Thank you for watching. Make sure to like, subscribe, follow us on Instagram for more at MidnightMed1200, and we'll see you in the next video.